This could be a little controversial case. Ma'am rightly said when I told her
We
that I did
purposely
this case.
thrown it in.
But I'd like to present a case of a 5-year-old boy who presented with inability to weight bear since 5 days. There's fever since 5 days. And all signs and everything seemed like there is septic arthritis, but the scans were not done, X-ray was not done. So it is purely clinical. So you have a 5-year-old, 5 days history with inability to weight bear. There is pain on movement of the limb, on rotation of the hip. Fever is there. So any of the students here, how will you distinguish whether this is a case of septic arthritis versus something like a synovitis or a transient synovitis? So I would like someone to answer, like, what are the ways in which you can differentiate between the two? Very common question. I think someone is raising the hand.
The mic has already been passed on. And then after that.
Yeah, both can answer. You can answer.
Yeah, so for transient synovitis, sir, on practice, it mostly the pain and everything goes away on giving a normal ibugesic or an NSAID. And on septic
Sometimes it may not go away immediately, but what are so basically the question here is, how will you differentiate and what is the described criteria?
So one important factor will be that there will be a lot of joint effusion in case of a septic arthritis, and in a transient synovitis the amount of joint effusion or the the pain on movement would be less as compared to a septic arthritis. That is one of the points.
Right.
And
Aisha, you want to add in the next point?
No, sir. So apart from the history that usually few weeks before they will be having some URI or something, on examination terminal movements are usually restricted or painful along with some restriction. In septic arthritis there would be movement restriction even from the early on when we start to move the joint.
Is there any
Okay.
pathognomonic way?
Can someone answer from the postgraduates, what is the criteria? There is a
Janki.
described criteria, there is a paper on it. So
Cockroach
exactly, so that is the answer that we are looking at. Even in your exams, that is the answer that we are looking at. So Cockers criteria, yeah. So can someone pass on the mic if you have? Yeah, thank you.
ESR more than 40, nil weight bearing, fever, a temperature of greater than 38.5 degrees centigrade, fever, ESR, nil weight bearing, and the counts, total counts more than 12,000.
Right.
So if you have all 4 positive, then it's a 99% possibility of a septic arthritis. Only one is 0.2%.
And then in a infection, the child is usually really sick.
Yes.
Whereas
Toxic.
in a transient synovitis, it will be otherwise well child, and the changes in the pain and this thing are usually dramatic. One day playing, next day fine, or playing in the morning and in the evening suddenly has a shoot up.
Right, so if you
Go
look
on,
at
Chintan, I
Cockers
think, yeah.
criteria, that was what I had documented on the page as well, because there was no other investigation which was available on the day when I saw. So it is difficulty to weight. So 2 clinical criteria and 2 biochemical criteria. The clinical criteria are difficulty to weight bear and fever more than 39. So fever 100 more than 100 degree Fahrenheit is 1, and difficulty to weight bear. So these are the 2 clinical criteria, and the 2 biochemical criteria. One is rightly said as WBC count more than 12,000, and what Cocker described was a ESR, but now also you look at CRP. So if CRP is raised and ESR is above 40, then that is a 4th criteria. So all 4 were positive in this case. Child was not able to weight bear. I already said fever was there, and even WBC count, if you can see there, it's 14,300, and CRP is I think it was above 40. So everything was positive, and so 4 on 4, so 99% chance of having a septic arthritis. Now I already mentioned this was a COVID era patient. So MRI was done immediately on the same day as I suspected there was septic arthritis, and on MRI you could see that there is collection in the on the left hip. There is, but there
Use
is
your
no.
mouse to point it out.
Yeah. I don't know, it's not seen there. Yeah, now you can see there. So there is synovitis here, okay, and but there are no bony changes as such, as except for some edema. So there is no osteomyelitis in on the left hip. So this is the scan, and that was the patient profile. So patient was in PICU. HB was 7, just 7. WBC count was 14,500, and CRP, as I said, around 36. I was getting difficulty in getting the patient to theatre for full anesthesia and surgical open, debridement. So, as like rightly said for the previous case, the treatment for any infection is to open and debride. We have to go in, take out the bug, and then start with antibiotics. At this stage, since there was difficulty in getting the child to the theatre, and the hemoglobin, I was told by anesthetist, please, build up the HB, wait for 2 days and do the open reduction. But I think that was loss of time in such a case when child was already in PICU, signs of septicemia already setting in. He was not in septic shock, but definitely was kept in PICU because tachycardia and other things were already setting in. So what I did for this case, so the ideal way to go ahead is, yes, do an open reduction, do an open debridement, arthrotomy, and then send for cultures and start with antibiotics empirically immediately post-op. Since I had difficulty, I had a person who was pediatric intensivist. He gave midas and ketamine, and I did the aspiration at least to get the bug out. So first what I did was did an aspiration from the medial portal. So subvastus. So how we do dye injection in arthro
When you do an
arthrogram. So subvastus, I just put an 18 gauge needle and aspirated. Immediately I got the pus. So at that point in time, I thought like child is sedated and probably I can just lavage it. At the same time, this was done with prior explanation that he will require open reduction. So I did a anterior portal, how we do for a hip arthroscopy. I put anterior needle for doing the irrigation, and then aspirated from the medial side. I did 4 to 5 times of 10 ml, and then once the clear fluid was available, was aspirated, then I stopped doing this, and then send this call for culture sensitivity and started on empirical antibiotics. So samples were sent for culture sensitivity. If the fever and symptoms would have persisted, it was definitely been taken for a complete arthrotomy and open debridement and further management as the child progresses. But however, the next day there was no fever and for the next 48 hours, and the child had improved. On day 2 we got the cultures, which was MSSA, which was already sensitive to which antibiotic was going on. So there is a paper by Indian Academy of Pediatricians where they have given what empirical antibiotics to be given. So cefazolin and cefuroxime. If in doubt, you don't have cultures, you don't have blood cultures are negative, that is the one that you start, like what we start for all our elective cases. Don't start, or pediatricians have tendency to start on vancomycin, linezolid, and meropenem. It is detrimental because if resistance develops, you don't have anything to go beyond that. Other antibiotics are only parental after that. So start with an empirical antibiotic, and then if it's MRSA, you will go on to the ones which are sensitive. On day 5, the CRP came down from 36 to 10, which was more than half reduction, so more than one. It is now 1/3. And once CRP is becoming normal, we shifted to oral. And this was the 10 days post-op clinical. The child is already walking around, able to sit cross-legged, squat and everything without any difficulty. And I think it was, I don't know, but it is just that the aspiration worked and whatever was done worked. But this is not the message that you want to give in. You definitely need to do arthrotomy and open debridement if situation persists. So However, when I went and looked back into the literature, there are papers wherein immediately on the day when the child presents, you can do an aspiration to get the bug, USG guided, or if you know the technique, then you can do it blindly as well, to get the bug and then do a formal open debridement. So the cons for the aspiration is there is less satisfactory drainage and it will treat multiple aspiration or further going on to do a open debridement. So the solution to pollution is pollution is dilution is the mantra. So as what also Darshan described in his case, good wash, okay, even after you've done a good debridement, you just dilute whatever is the pathogen there. Try to give a good wash. Multiple washes are very important. Surgical management, I'll just don't go into this. The literature that I was talking about are these. So the paper which says that using treatment with using needle aspiration or irrigation has worked in many of these cases. Arthroscopy, which I was describing, Prasad sir has already described this, doing a arthroscopic lavage, not doing a complete formal arthrotomy. If you have a facility and if you have the expertise of doing a hip arthroscopy, this is the way also that you can do minimally. And yeah, I think that is the case of septic arthritis.
So what we'll do